I'm talking about obesity and CF. I'm going to briefly review some history and epidemiology, discuss some potential causes and clinical consequences of obesity in people with CF, briefly touch on treatment, and then talk about some critical knowledge gaps and future directions. As we all know, the improvement in life expectancy for people with CF over the last 80 years has really been built on the backs of incremental improvements in therapy. And many of these therapies have been nutritional in nature, particularly the high-fat diet and pancreatic enzyme supplementation. And we've seen great progress with this. These graphs demonstrate the clear association between better nutrition and improved lung function, which really translates to more years of life for people living with CF. These were published in 2008 by Dr. Virginia Stallings, and you can see very clearly why the current nutrition recommendations are for BMI over the 50th percentile for kids and over 22 and 23 for adults, females and males, respectively. And over the last 20 years, we've seen dramatic progress working towards these goals. And currently, the median BMI for kids with CF is over the 50th percentile, and for males and females, the median is above their respective targets. Over this same time period, as one might expect, we've seen basically a third of the patients that were underweight in 1999, and this is adult data in the US, are underweight today, which is amazing. The sort of flip side to that same coin is that we've seen more than a doubling in the percentage of patients who are either overweight or obese. And to kind of hone in a little bit more granularity on this data, I have some data from the Australian Cystic Fibrosis registry, and it's really interesting because they actually define overweight differently in Australia. They use a cutoff of 27 kilogram per meter squared BMI, and they define that as high BMI. And you can see on the left is pancreatic sufficient patients in dark blue, and on the right is pancreatic insufficient patients in light blue. And although there's definitely a higher percentage of pancreatic sufficient patients who are impacted by high BMI, there is a substantial proportion of patients with pancreatic insufficiency who are also impacted. So I think that's important as we're thinking about our patient population here. So now moving on to some of the potential causes of overnutrition in people with CF. So the first, I think, potential culprit is the high-fat diet. And the dietary recommendations for people with CF focus on high caloric intake, up to 200% of the recommended daily allowance for the general population, and that 30 to 40% of those calories come from fat. And we know why that is. That's for good reason, because higher BMI historically has meant better lung function and longer lives for people with CF. However, there's some evidence that our intense focus on high calorie and high fat has translated into poor diet quality for people with CF. And survey data has found that people with CF consume excess trans fats and excess simple sugars on top of what is recommended, suggesting that maybe the diet quality is poor as we're seeking high fat and high calorie. We also know that eating habits in childhood really do impact how people eat in adulthood. And so, it's certainly plausible that the intense focus on getting as much calories as possible and as much fat as possible in childhood has translated into kind of chronic habits of unhealthy foods that could contribute to an epidemic of overweight and obesity among people living with CF. The other kind of big elephant in the room for every discussion is the impact of CFTR modulator therapies. We know that patients with CF on modulators, that we do see weight gain, though the trials of modulators were not necessarily designed to detect weight gain. A recent systematic review of 13 CFTR modulator trials, which did not include Trikafta, found pretty strong evidence of weight gain in patients treated with ivacaftor, but very little or mixed evidence for weight gain with Orkambi or Symdeko. And then we've already discussed this 5-year follow-up study of the US and UK CFF registries, and I'm presenting only the data from the US registry, but over this 5-year period, the ivacaftor treated adults gained 2.4 BMI points, and the matched comparator group gained 1.6 BMI points. So there does seem to be some additional BMI gain among ivacaftor-treated patients, though I think it's really important to note that even the non-ivacaftor-treated patients gained 1.6 BMI points over 5 years, which is rather significant. We assume that the impact from Trikafta will be similar to what we see from ivacaftor, given that they're both highly effective modulators. We don't have a lot of that data yet. A single center study did find 2.4% increase in weight in just 3 months after starting Trikafta, and I feel like that probably fits with what a lot of us are seeing with our patients clinically. In terms of the mechanisms of weight gain with modulators, this is also best studied for ivacaftor, and it's just really a fascinating question. Dr. Virginia Stallings did a really elegant study of 23 youth and adults before and after starting ivacaftor, and she identified 4 main mechanisms of weight gain with modulators, including improved fat absorption, increased dietary fat intake, reduced resting energy expenditure, and reduced gut inflammation. Which is really interesting. And there's another survey study that kind of approached this issue from another standpoint and found that patients had improved self-perception of eating after starting ivacaftor as compared to before, suggesting that maybe gastrointestinal symptoms are improving, that could be driving increased calorie intake in these patients. And then lastly, we know modulators must be taken with high-fat meals, and so for a subset of patients, this might just be resulting in higher fat intake than what they were getting before. And the last and probably most, what in my opinion may be one of the most salient reasons for rising rates of overweight and obesity among people with CF is that the rest of us are also becoming increasingly overweight and obese, and people with CF live in the same environment that the rest of us do. And so this graphic tries to kind of bring together some of the general population data with the CF-specific data, including NHANES data and data from the CF registry. In blue is the 20-year change from 97 to 2017 for US adult obesity. In red is US youth obesity. Green is CF youth and adult combined obesity, and then purple is overweight for CF patients with overweight. So you can see that, many of the trends are similar, basically, is the main point from this graphic, although people with CF, of course, are not as affected as the rest of us. So now moving on to some potential clinical consequences of overweight and obesity in CF, and first we'll start with pulmonary disease. So in the general population, we know that obesity is not great for lungs. Obesity is associated with reduced lung compliance, reduced lung volume, increased airway resistance, reduced respiratory muscle strength, and ventilatory disturbances. Now, we don't really know the significance of these changes in people with CF, and to some degree it probably depends on the BMI. But I think it's definitely a reason for pause, given that pulmonary disease is the leading cause of death in people with CF, that we consider the impact that obesity could have for these patients. And then just to make the point that although the cutoffs differ at different centers, obesity could impact someone's candidacy for transplant as well. This is a really nice study done at the University of Minnesota Adult CF Center, trying to really find is there a point at which higher BMI is no longer beneficial for people with CF. And although there's really a lot of scatter in this data, this group did identify a BMI cutoff of about 28 to 29 kilogram per meter squared, where you see really a general leveling off of improvement in FEV1 with further increase in BMI. And I should mention that other studies have also evaluated this and generally find that anywhere between 25 to 30 for a BMI is generally where you kind of see limited or diminishing returns in terms of improvement for lung function. Next, I'll go on to talk about insulin resistance and diabetes. I mean, that's of interest to this group. Progressive insulin deficiency, as Tony was saying yesterday, has really classically been considered the primary driver of CFRD progression. This is just one of many studies demonstrating this. This study was published in 1993, included 32 youth with CF. The solid black line is 2-year, the kind of pre-data, and the dashed line is the 2 years post-data. And they evaluated these patients as their glucose tolerance deteriorated. And you can see the drop in insulin area under the curve over that time period. Recently more data has become available suggesting that insulin resistance is prevalent in, or is a feature of overweight and obesity among people with CF and may play more of a role. This study of 290 adults from Montreal included 28 overweight adults, and they did find association basically between overweight status and reduced insulin sensitivity in this cohort of patients. Another study from this same group longitudinally evaluated what's considered older adults, over 35, over 4 years. And they found that the main change over time in those patients as they went from normal glucose tolerance to either impaired glucose tolerance or CFRD was reduction in insulin sensitivity, and their insulin area under the curve actually stayed the same. So really exactly the opposite of the data that I showed you from 1993. Just to kind of summarize the data here, rising rates of overweight and obesity among people with CF, I think definitely have the potential to precipitate CFRD. And given what we'd already talked about, that patients with CF have reduced beta cell mass, less hardy beta cells, I think their risk of progressing to diabetes in the face of increasing insulin resistance is probably more than what we would see in the general population. So briefly moving on to cardiovascular disease, which has to some degree already been discussed. There are very few reports of cardiovascular disease among people with CF, and there are many potential reasons for this, including fat malabsorption, low levels of LDL cholesterol, and the fact that people with CF historically didn't live to the age where you would normally expect to see those complications. For the matter of time, I will not go through this chart in detail, but basically to summarize, many groups recently have tried to assess whether overweight and obese people with CF have higher lipid levels. Generally speaking, people with CF do have higher triglyceride levels, and overweight or obese people tend to have numerically higher LDL levels and total cholesterol. Though many of those levels still fall within the reference range, there's definitely still something different about people with CF in terms of their cholesterol levels that deserves further investigation. And then lastly, just touching briefly on liver disease. Hepatic steatosis is really common with type 2 diabetes and can progress to NASH and cirrhosis. As we see higher rates of overweight and obesity among people with CF who may already be at increased risk for steatosis, that may become clinically relevant. There's a cross-sectional study that evaluated steatosis at a single center, and they did find higher BMI was associated with hepatic steatosis in this group of CF patients, but the patients still weren't actually overweight. So we need to better understand how this sort of plays out among people with CF. So I'll just briefly touch on obesity treatment in people with CF. Caloric restriction and exercise is really the mainstay of therapy for weight reduction. There are medication therapies and surgical weight loss therapies that could be considered among people with CF, but there are sort of specific considerations regarding the risk for pancreatitis and nutrient deficiencies that must be considered. And I think ultimately it really needs to be individualized for each patient. So in conclusion, CF patients are increasingly becoming overweight and obese, really mirroring the general population trends. The causes are probably multifactorial, likely exacerbated or to be exacerbated by the broad use of highly effective modulator therapy. I think anecdotally we've all seen that, but we don't necessarily have the numbers to prove it yet. The consequences of obesity and CF are just becoming evident and may differ from those seen in the general population. And individualized treatment is really needed based on careful risk-benefit analysis for a given individual patient. So key unanswered questions. This is the fun part, and I think I didn't leave enough time for it. So I think the one question that's really interesting to me is what should we consider the upper limit for a healthy BMI among people with CF? Should it be the same as we use for the general population? Should we follow the Australian nutrition guidelines, which have termed up to 27 as acceptable for people with CF? And I think you can make good arguments for both. People with CF with highly effective modulator therapies are becoming more similar to the general population, and so why would we pick a different cutoff for them if they're generally healthy individuals? On the other hand, people with CF are at risk for nutritional decline with pulmonary exacerbations, and that is still a factor with modulators, and so maybe having a higher cutoff is wise. And then should overweight and obese people with CFRD be treated with non-insulin therapies? This comes up again and again at these meetings. It is so interesting and controversial. Furthermore, should it differ for pancreatic sufficient and insufficient patients? Should it differ for modulator-treated and non-modulator-treated patients? And is there a point, a BMI or metabolic stress point, at which further weight gain is detrimental? Historically, we have used insulin to promote weight gain and lung function, which means longer lives. Is there a point where you hit a tipping point where further BMI gain is actually bad for the lungs and puts people at risk for other metabolic complications, in which insulin might actually be harmful to those patients? And we really don't have the data to say that, but I think empirically, one might assume that there exists some cut point. And then just lastly, how should we be changing nutrition guidelines for overweight and obese people with CF? Should we be starting to counsel people differently in youth? And I think the nutrition community has already started doing this, recognizing that we're going to have a problem if we don't start focusing more on diet quality. Will cardiovascular disease become more prevalent in a healthier modulator treated patient population who are living really long lives? And a question of interest to me, will obesity-associated hepatic steatosis translate to higher rates of CF liver disease and cirrhosis in people with CF? And there's many other unanswered questions, but I'll stop there. Thank you.